So my colleagues and I have been working on the issue of surprise billing since the beginning of the Schaeffer Initiative in early 2016. And it's been striking how much interest in this issue among policymakers has grown since then, and how many states have enacted policies to address it, and this continues to accelerate. A grant from the Laura and John Arnold Foundation made last year has enabled us to substantially expand our activities on surprise billing and has led directly to this conference and the paper on policy options for states that was released in February around the original meeting dates. We're grateful for their support. We're focusing, and I think everyone is dealing with the issue, is focusing on the subset of services for which patients cannot choose a provider. And of course, this undermines the potential for having a competitive market. So if the patients cannot choose, the only motivation for providers to be in network is the challenge of collecting from patients instead of billing an insurer. The result is very high network rates and large balance bills for unlucky patients. And while this is a bad situation, especially for patients, a silver lining is that it's been conducive to bipartisan, or more accurately, nonpartisan, efforts to find a solution, both in states and more recently in Congress. The conference is going to begin with Lauren Adler's presenting the paper that was released in February and taking questions from the audience. Lauren is Associate Director of the USC-Brookings Schaeffer Initiative for Health Policy, and he did an outstanding job in leading the preparation of the paper and navigating the challenge of having 6 co-authors, all affiliated with the Schaeffer Initiative, and all of whom made substantive contributions. After Lauren takes questions from the audience, we'll turn to Mark Hall, who's a non-resident senior fellow at Brookings and the Fred D. and Elizabeth L. Turnage Professor of Law at Wake Forest University and a co-author of the paper, to moderate a panel of policymakers who've been working on this issue, 3 at the state level and 1 at the federal level. And finally, after a break, I will moderate a panel of stakeholders that expect to be impacted by policies to address surprise billing and are trying to influence the policy process. Lauren?
Hi, everyone. Thank you for the introduction, Paul. I think he covered the basics of what we did, and obviously thank you to all the co-authors on the paper as well. This would not have happened without everyone's work on this issue. So I think I wanted to start. So today, I'm basically kind of walk through really kind of why these surprise bills happen, what they are, although Paul mostly touched on that already. And then I'm going to kind of talk through what the different policy solutions look like and sort of where we come out in our paper for recommendations, and also thinking through what the impacts of different policies addressing surprise billing might be. So just to take a first look, Paul sort of touched on this, right? We kind of define, it's useful to kind of define what is a surprise out-of-network bill. This isn't any out-of-network bill you get, right? This isn't any surprise you get. We're really kind of focusing in on sort of 3 main types of examples. So one is, this one gets written up a lot, is you have a heart attack, you get hit by a car, you call 911, the ambulance is dispatched, takes you, and it takes you to the hospital. It turns out the hospital you get taken to is out of your insurer's network, and they can hit you with a large bill, or the ambulance that took you there is not in your insurer's network. And then there's sort of the more common cases that get talked about here, where most people actually, even in emergency situations, are choosing in-network emergency departments, in-network hospitals. But then the emergency physicians who work there, or the surgeons on call, whatever doctors might be on call in the emergency room, they are out of network, right? So those doctors are negotiating independently with health plans from the hospital. So it is very possible, and is not uncommon, that you have a hospital who is in network, but the emergency medicine physicians who practice there are not in those same networks. And then the last example here is, right, this can even happen with elective care. So I pre-plan, I'm getting a hip replacement surgery. I call ahead to make sure the make sure the hospital is in network, to make sure the surgeon who's going to be doing the operation is in network. But I go get my surgery, and it turns out after the fact, the anesthesiologist or the radiologist hits me with a surprise bill, and they were out of network. And I had no plausible way, and I think it's sort of impossible to imagine people actually choosing their anesthesiologist beforehand. And honestly, go ahead and try to do this. I've tried before my wife gave birth, and I tried to call the hospital, and it took me 8 calls to figure out. And even then, I was like, I was given like a 90% sure answer. Right, and so. I think it's useful. I'm going to talk mostly in this presentation, I'll mostly reference sort of as the examples, emergency medicine physicians and anesthesiologists, just because that's really where the overwhelming sort of surprise balance bills are kind of coming from. But really, this is also at least somewhat common among pathologists, radiologists, definitely ambulances, both ground and air, and also less commonly for kind of any other types of physicians who are working in the emergency department, and more occasionally for sort of neonatologists. It could be right after a birth, you need a neonatologist instantly. Who might not be in network, and hospitalists. I know recently there's been some private equity activity buying up hospitalist physician groups, or sort of the doctor who while you're during your hospital stay, the doctor who kind of works at the hospital who comes and checks up on you, more sort of a primary care type who you typically don't choose as well. So that hasn't been a problem much to date, but I am somewhat nervous that that will become a problem in the future. Right, we've read a lot. We've read a lot about anecdotes of these, and there's a lot of great stories in Kaiser Health News and Vox on the sort of individual examples here. But it's worth looking at. Right, this is actually a pretty somewhat common phenomenon. This isn't really just a few one-off anecdotes. From the few research studies that have been put out there, it looks like about 1 in 5 emergency department visits result in the potential for a surprise out-of-network bill. And that means, right, you went to an in-network hospital, but one of the doctors who treated you is out of network. And even in the 1 in 10 times that you do that elective procedure where you pre-scheduled everything, there are 1 in 10 times that you are seen by an out-of-network anesthesiologist, radiologist, et cetera. And then the ambulance cases is kind of an interesting one. So about 50% of ambulance rides in the one study that's looked at this with a pretty large insurance data set found that about half of ambulance rides were out of network. And a GAO report, I think yesterday or the day before, found that 69% of air ambulance rides were out of network. And for air ambulances, it's just really hard to fathom how there could plausibly be a market for these pretty rare events that are pretty much mostly emergencies. So I think the first thing I kind of want to do is take a step back, and in which it gets lost in some of the discussions here, is why does this happen, right? Well, what is going on that allows surprise bills? Why does this happen here and not in any other industry, right? And so really there is a market failure going on here, in my opinion. So right, for a normal doctor, for your typical physician, your cardiologist, neurologist, whoever it might be, right? They go to an insurance company, and the insurance company says, look, I'll steer my enrollees your way if you give me a price concession. That's sort of the standard price-volume trade-off that exists throughout the economy, not just in healthcare, and that works, right? Your cardiologist can't practice without being in insurers' networks, right? If they don't sign up with health plans, they see 0 patients and they make $0. But we just flip that around. When we talk about anesthesiologists or emergency docs, that's simply not the case. So there's no real price-volume trade-off here because the health plans aren't the driver of volume for them. They can, an anesthesiologist, if they don't contract with the health plan, they still see roughly the same number of patients because patients are choosing the hospital and not the emergency or ancillary conditions. And right, as a result of that, they have this potentially lucrative out-of-network billing option of these sort of captive patients that no other provider type has. And as a result, this is why, as Paul kind of hinted at, we see very high in-network rates for these physicians as well, and also very high bill charges, which I'll kind of get to in a minute. Right, and the kind of thing is, right, they still might go in network. It's still sort of a pain collecting from patients. Most doctors don't like surprise billing patients and going after them, so that's why you still see some, but that's really the only thing stopping surprise billing, and that's, in my opinion, that's why you've seen sort of bigger companies come in here and who have maybe are more efficient at collecting from patients and might have less qualms about collecting from patients also, and they can then more efficiently sort of drive up rates. I think it's also worth talking about here, the hospital actually plays a very big role in these negotiations. That's really where the actual market is here. The real market here is between the hospital and the anesthesiologist rather than the health plan of the anesthesiologist, right? So it's the hospital who drives volume to the anesthesiologist, right? They pick the hospital and they get a surgery, and then because they're at that hospital, they see that anesthesiologist. And that's really, and the hospitals obviously need anesthesiologists also. You can't be giving surgeries without having anesthesia. So right, there's just a very natural market where there's a price volume trade-off there. And right, there's already a lot of money flowing between the hospitals and these types of doctors. There's contracts right here as well. Hospitals are typically trying to pressure these physician types to join the same networks that they're in. It doesn't always work, but almost every hospital I've talked to at least says that they are trying to sort of pressure these docs to do this. And right, and the reason they do this is because right, they suffer. A hospital, all else equal, doesn't like surprise billing happening at their hospital either. That looks bad for them. Right? There was a study recently that basically said women who give birth at a hospital and get a surprise bill are much more likely to choose a different hospital the next time around. So right, there's at least some impact on the hospital, and that's why right when you see sort of the emergency doc group balance billing patients, surprise billing patients at a hospital, typically they're sort of compensating the hospital to allow that to happen. So right, the typical case that I've seen written up a lot of times and that I've heard just a lot of times is a sort of staffing company or like Envision, the poster boy for this, will basically go to the hospital and say, look, I know you're currently paying a $300,000 subsidy to your emergency doc group to kind of get them to practice here. Look, you don't have to pay me anything, but just don't tell me how to bill patients, and I'm going to go surprise bill them. And they're sort of, so right, so there's already a little bit of money changing hands to kind of allow this today. Right, so that's sort of the theory behind why this has been a problem and why I expect it to happen. I think it's kind of worth now turning to the data to see why that does happen. So right, given that they do have this lucrative out-of-network billing option, it's no surprise that these types of specialists really lean into that leverage and bill really high amounts. So this table here, right, you see that the exact types of physicians we're talking about, your anesthesiologists, emergency docs, radiologists, are billing, right? Anesthesiologists are billing 5.5 times the Medicare rate on average. The 80th percentile, so that means, right, only 20% of anesthesiologists bill above that amount, and 80% of anesthesiologists bill less than that. So that means that 20% of anesthesiologists have billed charges at 11 times Medicare or higher. That is a very, that's a pretty jarring amount, and you can see right down below, take every other specialist, they're almost all in the sort of 2 to 2.5 times Medicare rate. And you can look through the entire list of specialists. There's no one up at these levels other than these specific types of doctors. This is just maybe hard to read from where you're sitting. But this is just to put a little bit of numbers to this and kind of look at how big these balance bills can actually be. And right, so especially when you're talking about emergency medicine and anesthesiology, these bills can often be, in the $1,000 range or more. In the emergency setting, often you're also getting seen by not just an out-of-network emergency doc, but an out-of-network surgeon who might be billing you $10,000. So that's the cases where you're getting like the really large bills. But even the anesthesiologist, right, the 80th percentile charges here, that's $1,300 rather than the maybe $300 that the insurer would pay. That leaves a pretty large amount of money that you're trying to outlay, and these are just sort of chosen to be the most common procedures for these plan types. The other thing here, right, is this isn't just this gets kind of lost, I think, sometimes in the discussion, is this isn't just a problem for the people who get the surprise bills themselves. Obviously it sucks to get the surprise bills, but because of this leverage to surprise bill patients, we see that these physician types get paid more money when they do go in network. And as a result of that, that means that the insurance companies are paying more, right, and we are all paying higher premiums as a result. Right, you see anesthesiologists getting paid 350% of Medicare on average. Emergency docs are up around there too. And right, so when you look at across other types of specialists, they're much more in the, pretty much every other specialist is somewhere in sort of the 125% of Medicare to 150% of Medicare range. So these are just very large outliers. And I just want to, right, the natural sort of contradiction to this is, right, Medicare rates are not perfect. And I'm not trying to say that the Medicare rate for each of these specialties is dead right. Right, they have budgetary constraints, et cetera. But they are our best estimate of costs of delivering these services. So they're not really trying to say that the Medicare rate got it exactly right, but it's just too coincidental that we see crazy high rates for these exact types of specialists and charges for these exact specialists that you would expect, that economic theory would predict, and literally no one else. I think that coincidence is too grand. So, maybe the market rate for anesthesiologists isn't 130% of Medicare like other specialists, but I'm pretty darn sure it's not 350% of Medicare. All right, so now, right, I think I've established this is a problem, or I hope so. The next question is, right, how do we solve it? I think I'm going to kind of walk through a few options here, but I first sort of wanted to touch on just sort of the overview of kind of what we see as some of the keys to addressing this issue. First, I think it's important to take patients out of the middle when these happen. I think it's unrealistic to expect patients to be selecting their anesthesiologist or their emergency doc. I think that's too unrealistic. So I think when you're talking about a solution, you kind of want to take them out of it and leave it between, insurer, hospital, and provider. I also think it's important to be comprehensive. So a number of states, especially older laws on this issue, really only address this situation in emergencies and for emergency services. I think it's important, this is clearly a problem, not just in the emergency setting, to be broader than that. Similarly, some older state laws only address this in HMO plans, so in narrow network type plans. The data that I've seen, it seems the prevalence is pretty similar across PPOs and sort of broader network plans as well. There's really no reason to kind of narrow this into just HMOs. And then something I'm going to harp on a bit is that even states do have a lot of authority to protect the folks in self-insured plans as well. So just to define what self-insured is. So basically, most large employers basically handle the risk of their health costs themselves, meaning they self-insure. So right, that if they're kind of on the hook for the health costs of their employees, even though they're using an insurer to kind of administer the benefit. But that's about half of the commercially insured lives in this country. And the law known as ERISA prevents states from telling those plans what they can pay or telling them sort of to regulate those plans themselves. But you can still regulate providers. And I think the solutions we're focusing on allow you to kind of focus some of the regulations on providers to basically provide that protection to everyone in your state rather than just half of your state. And then I think this last one is the other thing I will harp on a lot is please avoid policies that increase health spending. I think we want to avoid solving one problem while creating another. All right, so I think I want to start with, we have two broad swaths of solutions here. The first one that I'm going to talk about here is that we term billing regulation. This is what every state who's addressed this issue to date has done some form of this. The typical way this happens is it's basically most states this is a three-part thing where you basically prohibit the provider from balance billing in the surprise cases. You tell the insurer to treat the services in network, and then you set some sort of minimum payment standard that the insurer sort of has to pay to the provider. What we're kind of talking about here is it's equivalent, if the federal government was doing this, it's exactly the same thing, but just flipping that slightly where you put a cap on this physician's charges, so that out-of-network charge rate. If you put a cap on that at a reasonable rate, that largely solves the problem for everyone in your state. Because even for folks in self-insured plans, if the anesthesiologist can only bill 200% of Medicare, the insurer all of a sudden now actually has an incentive to take care of that, right? The insurer there is some harm to insurers when their enrollees get surprise billed. It's just sometimes it's not worth it for them to pay 10 or 12 times Medicare rates to get that away. But if it was 2 times Medicare, I'm confident you would see insurers sort of just treat this, and the problem would pretty much go away for everyone in your state. So I think that avoids the ERISA preemption issue. You'd combine this still with requiring your fully insured plans to treat the services in network, so you kind of do close the loop entirely for the plans that you can address. And at the federal level, obviously, you can do that for all plans, and there's sort of doesn't really matter which one of these you do. So I think the next question is, right, how do you set this limit, or how do you set this payment standard? That's kind of the fundamental question here. And in particular, I like to kind of frame this as sort of a question of too high versus too low when you're setting this. So, right, if you set a high payment standard, if you set a rate above what doctors are currently getting paid as sort of the out-of-network payment standard, every doctor basically can just go out of network and get that rate. And you'll see rates climb up to that level, premiums go up, costs go up, et cetera. That one's like it's a pretty straightforward mechanical thing if you set a very high payment standard. The flip side, however, is not equivalent. So if you set a payment standard that is too low in some sense, that is actually below whatever kind of their normal market rate is, which I think is probably a good amount below what they're getting paid today. If you set a payment standard that's sort of on the low end, right, there's a natural market here between the hospital and the physician. So in that case, the hospital still needs the anesthesiologist to practice. So if you set a payment standard at 100% of Medicare, the hospital goes, okay, they go to the insurance company and say, okay, look, we need our anesthesiologist to actually practice. So here, insurance company is sort of a part of the negotiation with us. Just offer our anesthesiologist 150% to Medicare. That's probably closer to the market rate, and then that'll be part of our kind of agreement. Or the alternative is, right, the insurer refuses to do that, and the hospitals just sort of pay the anesthesiologist directly, something like 50% to Medicare, and sort of top them up effectively, and then they build those costs into their negotiations with the insurance company. And right, I know this sort of it sounds unusual, but this really happens today on a smaller scale. Right, it is very common right now for a hospital that has a high share of Medicare or Medicaid patients, for instance, to basically, because an anesthesiologist who works at a hospital that has a lot of Medicare patients is effectively getting paid less money by plans, because Medicare is paying a third of private payers. And in those cases, we see hospitals paying those anesthesiologists extra money to practice at their hospital rather than the one that has mostly privately insured patients. That's really the same dynamic on a smaller scale, but I have no fears that this would happen in practice. Getting into more of the specifics of kind of the actual benchmarks that people tend to choose, our huge caution is just please do not base anything on physician bill charges. This is a completely made-up rate that has no basis and is completely untethered to the market. It is sort of the provider's wish price. It's not a list price, right? The MSRP on your car. It's something that no one actually pays. I mean, uninsured patients are liable for it, and surprise bill patients are liable for it, but there's basically no control on it. And these tend to be, I mean, we looked at those slides earlier, right? These tend to be, 10 times Medicare, 5 times Medicare, and at least double contracted rates when we're talking about these, and they're just very high numbers. I also think, ideally, we'd avoid basing this on current contracted rates also, because they are already way too high. So if you base something on current contracted rates, you are basically baking in the high costs that we're already paying for these services, and sort of rewarding the types of specialists that have sort of been benefiting from the market failure status quo. So ideally, you would set something lower, and we'll kind of get into recommendations in a slide or two. I just wanted to touch on, I think some of my authors, more than me, are somewhat uneasy about using the sort of the other approach, right, to setting a rate is to sort of kick this to arbiters to kind of make the decision of what the rate should be. In some ways, like, the same considerations apply, right? As long as you tell them to kind of consider low rates and don't tell them to consider charges, it'll end up pretty similar. There's some extra administrative costs, but there's also just some lack of transparency and kind of risk of there's no reason to think that arbiters are better at picking kind of the appropriate rate than lawmakers are. Obviously, there's a political expediency to not having to choose the exact rate, but that's sort of the key. And I think just to kind of drive home the do not base anything on bill charges point, Fair Health released this data recently from New York data, basically looking at here's what the 80th percentile of charges are, and here's what the median in-network rates are in New York for a few of the sort of very common surprise billing cases are. The incentive is blatantly clear, right? If you are a emergency doc making $320 currently in network, you can just go out of network, go to the arbiter. The arbiters are basically told in New York to consider the 80th percentile of charges, this very high rate. My understanding is that arbiters almost always pick whoever is closer to that number. So you can just go out of network and get paid $1,200. So, my rate or 4 times that rate. It's a pretty straightforward incentive there, and I am, there are some things in a state law that kind of prevent it from spiraling too far, but if you did this at the federal level, you would see rates climb up pretty close to those high levels and have premium impacts, budgetary impacts, et cetera. So the other type of recommendation that we walk through here is what we term contracting regulation. But this is basically you would prohibit emergency and ancillary clinicians from billing independently to either health plans or patients for their services. So right at that point, they would contract for payment with the facilities rather than the health plans, and then the hospital would then bundle that in when they're negotiating with the health plan to get paid. The analog here is nurses. Right now, hospitals pay nurses, and then they build those costs into their negotiations with health plans. And this also has the benefit of, because it is exclusively regulation on providers, there is no ERISA constraints, so this could, if a state enacted something like this, it would apply across the board. The vision for this is that you're actually creating a real market where a kind of broken market exists today. This sort of creates something much more approximating a real market. Markets can still have other issues of high market power, but that's sort of a separate issue. walking through our kind of recommendations. We have two main recommendations, which we actually think work out pretty much the same. The first is that you would do the sort of billing regulation approach and tie a payment standard to what other specialists get paid relative to Medicare. So, right, I was saying earlier, other physician types tend to get paid about 125, 130% of Medicare. If you tied the payment standard to that, I think is a much more reasonable thing to do. This is something I think is a very reasonable argument. You can vary that by state and market still. And just given what I was talking about before, there's really no risk to setting a rate below their market rate. We would sort of err on the low side of that, so we recommend sort of setting a rate at 125% of Medicare. And similarly, right, if you're going with an arbitration approach, you could give policymakers the same guidance, right? You should consider what other specialists, or maybe name a list of specialists, get paid relative to Medicare in your market. But the problem with this is that this only, and then jumping to the next one is, right, talking about this contracting regulation. I think you would want to, is sort of the same thing, you'd apply that to all your facility-based services. The problem is that doesn't help you for those few cases of the first ones I talked about, of the out-of-network emergency department or the ambulances. So in those cases, you would still need the billing regulation approach, just because there's no facility at play it wouldn't help you at that point. And then sort of lastly, just sort of wanted to walk through, obviously we're in Washington, D.C. right now. There are probably federal policymakers watching this. Most of the paper was kind of focused on states, but honestly, like, the same considerations basically apply. There's not a whole lot of difference in how you want to think about this. The main thing is, right, you can just ignore all the things I said about ERISA. If you're talking about a federal lawmaker, it's very easy to regulate self-insured plans at the federal level. I think the other big one is states are prohibited by FAA regulation from touching what we pay for air ambulance services. So at a federal level, you can much more easily just sort of fix this problem on the air ambulance side, which seems to be a pretty jarring problem with, right, 69% out of network, $10,000 balance bills here we're talking about. And really the same solutions we've been talking about on the billing regulation aside. Same thing you'd apply to ground ambulance should be applied to air ambulance. So here. And lastly, right, there's a question at the federal level of what do you do with existing state laws? When do you preempt them and stuff like that? Right, this is kind of an open discussion to your own preferences. I think my view is you would preempt anything that you don't consider a particularly strong law. So maybe you'd even pick a few states that have laws, or say, we're going to allow anyone who has a payment standard less than 150% of Medicare can keep that law will still hold, and if not, it's preempted by federal law. But obviously that one's a little bit more of an open question. And on that note, that's sort of the presentation, and I wanted to open it up to audience Q&A for 5 minutes or so. Or 5 minutes, 20 seconds.
Hi, David Lesser. I'm a consumer, not in the business, but I do own a small business and I struggle with paying for insurance and how much to pass on to my employees. Every year it goes up, et cetera. But I have just a couple of comments. One area that you didn't discuss were these freestanding surgical facilities. And I know from experience, you sign up for a colonoscopy with an in-network doctor, and they do all their colonoscopies at this freestanding facility, which they may or may not own part of. And afterwards, you find out that it's out of network, not the doctor, but the facility, and you get walloped with that fee. And when you get an out-of-network bill, I mean, you've talked about how much higher it is, but the other problem is that typically your out-of-network deductibles are much higher, so you may end up paying 100%, not just the excess over what the insurance company covers, because they're not going to cover any of it. The other point I wanted to make was another recent experience. My wife had surgery at a local hospital, MedStar. I think a bigger problem are the hospital facility fees. The facility fees for her surgery were absolutely outrageous, and they were in-network. And the discounts off the facility fees negotiated by the insurance company were negligible. So if the hospital, for example, has to pay a doc because your plan ends up having the doc fees limited, the hospital has other ways to generate income, and that's through much, much higher facility fees. And I think that's as big a problem as this. And the final question I have for you is, in a lot of regulatory settings, when you fix a problem, you're fixing the problem, the loophole that somebody found, or the way around regulation somebody found. You have to test these solutions to find out whether the doctors, the facilities are going to find a way around your new fix and just find another way to jack up their charges.
Yeah.
Thank you.
Thank you for that. No, I should have mentioned, I kind of glossed over by just using the word facility without ever defining it. But I certainly, this is a problem in freestanding emergency departments as well as freestanding ASCs, or the ambulatory surgical centers. So that is certainly something you want to be looping into to these protections. Right, on the hospital side, I agree that is a problem of hospital market power, and we pay very high rates to hospitals in general. To me, that's somewhat a separate, I think it is a very important policy topic. It's just somewhat separate from the direct surprise billing situation. And I mean, obviously, right, there's going to be, I'm sure when we pass this, there will be some small loophole that we missed. But I think that's sort of, right, there's always sort of a game of whack-a-mole to some degree. I think this catches the 99% of the cases at least. I'm much better in that situation than with 100% being there. Oh, I guess Bruce already. Sorry.
The power of the mic.
Yeah. Go, Bruce.
Bruce Steinwald. To make sure I understand a surprise bill, if I'm hospitalized and I get a surprise bill from the anesthesiologist and it's high, I'm still covered for at least some percentage of what the insurance company would have paid an in-network anesthesiologist, right? So if it's $10,000 and they would have covered $2,000, on the one hand, I have to pay the bill and then submit to the insurance company. They're only going to reimburse me for some fraction of the in-network amount. Is that true? So what actually happens? What does your data say about what people who are confronted with these surprise bills actually do? Do they pay them? Always? Sometimes?
That's a good question that sadly we do not have good data on at all. I mean, I've talked to a lot of people at this point. Look, most of the time that these potential surprise bills are showing up, the patient, most of the time the insurer, or a lot of the time, the insurer and the physician are kind of working something out. A lot of times the insurer, just at the end of surprising amount of time, the insurer ends up just paying the full bill charges because the complaint's too loud, and that's why we see even higher premiums. But right, a lot of times this does get worked out before, but right, in that case, the anesthesiologist, right, you were liable for probably 30% of that $2,000, and then on top of that, the anesthesiologist can legally bill you the remaining $8,000 balance, and you have no actual legal recourse. Well, some people argue you do, but you don't want to spend $10,000 on lawyers' fees to do that recourse. But they can bill you, and I think that the fact that they can bill you is why they get paid so much in network. So the fact that it gets resolved half the time or something, or maybe probably more than that actually, doesn't absolve that the problem exists. And let's do one more question, and then.
Hi, Joyce Frieden, MedPage Today. You said you were talking about negotiating a cap as one of the options, and you said if you negotiate it low enough that the insurer would have an incentive to pay that. Can you expand on that a little? Why wouldn't they just let the patient pay it if it was low enough?
Sure. So I think our view is that, right, so right now, often when this happens, when a patient gets the sort of surprise bill from the anesthesiologist, often the insurer is paying the full, even like crazy high bill charges. I think the point is, right, it is to an insurance company, it's worth something to not have your enrollees be balance billed, because otherwise you'll lose customers to other insurance companies. It just might not be worth paying 10 times the Medicare rate for these types of services. But right, in the markets where there's a few markets where these doctors are paid much more normal levels, right, then you don't see this issue happening. Right, the insurer, all else equal, does want their anesthesiologists in network at the hospital. It's just, right, if they could just pay a normal market rate for it, they'd be happy to do that. And I just think the downside from allowing your enrollees to get surprise billed is worth paying that much more reasonable cap. It might not happen 100% of the time, but at worst, you've also at least limited the surprise bill also, right? At least the surprise bill is more reasonable. But my theory would be that almost all the time, the insurer would kind of take care of it at that point, right? I think the insurer is sort of taking care of it the large majority of the time now. So I think in that case, they would almost always take care of it.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.